Welcome everybody. My name is Dr. David Crepaz-Keay. I'm head of empowerment. I'm head of applied learning at the Mental Health Foundation, and it's a real joy to welcome you all here to this joint meeting between the Mental Health Foundation and the Cardiovascular Research Trust. And today we're going to be looking at the really close links that exist between cardiovascular health and mental health. Mental health is something that's been hugely important to me. I've been working in the mental health field now for well over 30 years. And during that time, it's become increasingly apparent that mental health and physical health are incredibly closely linked. And we'll be exploring some of those links, particularly as they pertain to cardiovascular health in more detail today. But along with broader mental health and its impact on physical health, my other great passion is how we engage and harness the power of lived experience to extend and expand the quality of research that we do in these fields. And I've been fortunate to work in mental health research with a huge number of people with lived experience over that time period, and it's been a real joy to see how much new and valuable knowledge has been generated by the power of people with lived experience working together with people from more traditional backgrounds, and really expanding what we understand knowledge to be, and really expanding, pushing the limits of our learning in a way that wouldn't be possible either for service user researchers alone, or for academics alone to do. And I think one of the things that I'm looking forward to today is understanding the new and expanding knowledge around the links between mental health and cardiovascular health, what that actually means for people, but also how people with lived experience have contributed to that knowledge base, and how we can all jointly apply it to improve quality of life for all of us. I am familiar with some of the panelists who I've had the privilege to work with closely over the past few years, and in the case of Chris, many years. And I'm also looking forward to the panelists who are new to me, but have extremely exciting presentations and perspectives to offer. I will introduce people in more detail as we come to each presentation. And I must, before I go into that, remind people that this is part of World Healthy Life Week 2022, which has the theme Big Questions, and I think we'll certainly be approaching some big questions today. It's, as I said earlier, a partnership between the Cardiovascular Research Trust and the Mental Health Foundation. And we would really love people to tweet about this webinar using the hashtag World Healthy Life. There will be opportunities for a decent question and answer session after all the presentations have been completed. So, but please don't wait for them to jot down your questions. As soon as a question occurs to you, please use the Q&A function that we have in Zoom. I have colleagues in the background who are keeping an eye on the questions as they come in, and we will be looking at those questions in more detail, and all panelists will have a chance to respond to those as they towards the end of the session. So please, if questions occur to you during what I know will be some very stimulating presentations, please jot those questions down using the Q&A function, and we'll address as many of them as we can towards the end of the session. So without further ado, I will start by introducing Marianne Downing. I had the huge privilege of working with Marianne during her masters, her global mental health masters at the London School of Hygiene and Tropical Medicine and King's. She is a pharmacy professional from Northern Ireland, with experience spanning all areas of health systems, including community, hospital, and primary care settings. I know Marianne's presentation will be looking very much at the evidence for the links between cardiovascular health and mental health, and what that means for us in practice. So without further ado, I will hand over to Marianne. Thank you.
Thanks very much, David. And yeah, it's a real privilege to have been asked to present today, especially with some really influential people here. And again, David, so he helped me with my dissertation last year as my supervisor, and he definitely kept me on the straight and narrow, as well as kind of learn a bit about making cheese along the way. So yes, with regards to my presentation, I'm just going to stop my video just because I'm afraid of it kind of cutting out. So I'll just share my screen here. Let's see. And I'll get started. Okay, so can everyone see that okay?
That's looking good, Marianne.
Perfect. Okay, so today we're going to go on a journey together to discover and explore the key evidence between circulation, heart health, and mental health. So whenever I refer to cardiovascular health, I'm referring to circulation and heart health. Okay, so just as a brief overview, what I'll be discussing is what actually is mental health, and then we'll move on to the facts, so the epidemiology of cardiovascular disease and mental illness. Then I'll kind of take a wee kind of quick history lesson on the links between heart and emotions throughout the ages, then have a look at where we are now and then where we're going, so future directions. So what is mental health? So according to the World Health Organization, health itself is defined as a state of complete physical, mental, and social well-being, and not merely the absence of a disease. And then with regards to mental health, again, it is not just the absence of a mental disorder. It is defined as a state of well-being in which every individual realizes his or her own potential, can cope with the normal stresses of life, can work productively and fruitfully, and is able to make a contribution to his or her community. So really here, we're thinking of a shift towards psychosocial well-being and a social and emotional well-being. And the thing about mental health is it is fundamentally personal and subjective. So what I would consider good mental well-being might be completely different to what you might consider it. So it's a really quite a spectrum and you can't really classify it. Okay, so looking at the facts on mortality and morbidity regarding cardiovascular disease and mental illness. So cardiovascular disease is the leading cause of mortality in almost every region of the world, with an estimated 32% of all deaths worldwide. Now, depression isn't kind of like one of the main leading causes, but it is definitely an independent association with all-cause mortality, with figures as high as 50%. So depressed individuals generally have higher rates of respiratory, cardiovascular, and infectious diseases. And in fact, depression doubles the risk of coronary heart disease in adults. Now, patients with severe mental illness, such as schizophrenia or bipolar disorder, die on average 16 to 25 years sooner than the general population. Now, looking at the aspect of morbidity. So morbidity with regards to the global burden of disease, neuropsychiatric disorders account for about 14% of that. So that's looking at both communicable, which is infectious diseases, and non-communicable, which is chronic disorders. And this is taken from No Health Without Mental Health in the Lancet. So this is to do with the non-communicable disease burden, which is kind of a measure of the burden is disability adjusted life years. So as we see here, the neuropsychiatric disorders account for 28%, which is above cardiovascular disease and cancer. So really, what is the link between the heart and emotions? So again, we're just going on a bit of a history trip here. So we start off the timeline in the 1300s with the explosion of heart imagery in the arts, and especially in France. So this is an art piece called the Heart Offering. And here we see a woman raising a heart that appears to have been gifted by the man facing her as a sign of love. She accepts the gift while he touches his breast to indicate the place from which it has come. The metaphorical heart seen here almost acts more in line with our understanding of mental health as opposed to clinical heart health. And this was taken from an illustration from the Romance of Alexander. Then jumping a few hundred years in the future, in the 1600s, we've got an influential physician here, Thomas Willis, that wrote and published a text called Cerebri Anatomy, where he actually attributed the source of emotions to the brain and the cardiovascular system. So he kind of described a three-component soul, with one of those souls called the vital soul, also like in Latin called the flamma vitalis, which acted within the blood. And then jumping another few hundred years to the 1950s, we've got two renowned cardiologists, Meyer Friedman and Ray Rosenman, who described for the first time the type A personality behavior as a potential risk factor for heart disease and high blood pressure. So with this here book that they had written, type A personality is characterized by a constant feeling of working against the clock and a strong sense of competitiveness compared to the type B, which has a more relaxed approach to life. But basically we kind of understand now it's more of a spectrum between type A and type B. So that was a real kind of whistle-stop tour, but now we move on to current research. So what is our current understanding? Now, this is a systematic review of prospective cohort studies, just the findings from it and from Hemingway. And so there's basically a moderate to strong evidence that depressive and anxiety disorders are independently associated and a prospective risk for cardiovascular disease, with the outcome measures angina and heart attack, either non-fatal or fatal. Now, looking more specifically at depression and heart attack, based on kind of a meta-analysis prospective cohort study, there's a moderate to strong association of heart attack and depression. Also, we have this bidirectional effect where there's an increased incidence of depression after a heart attack, and it increases to 15 to 30%, especially within the first 30 days. Also, we see a kind of almost going full circle again, the comorbid depression, it's constantly kind of a predictor of future recurrent events and all-cause mortality. Now, treatment of comorbid mental disorder is effective in improving quality of life and mental health. However, there's mixed evidence on mental health interventions for improving physical disease outcome. Now, interventions that kind of have been studied with regards to physiological that focus primarily on stress management. There's no real reports on the cardiac or all-cause mortality, but there is a small reduction in kind of depression and anxiety scores. For heart attack, with regards to pharmacological interventions, SSRIs, which are selective serotonin reuptake inhibitors, which are kind of a very well-known antidepressant, have shown to be safe and moderately effective for depression post-heart attack. Now, both combining those two together, there was a significant improvement in mood, however, not in overall survival. So now looking at depression and its association with stroke. So depression is an independent risk factor for non-fatal stroke. For fatal stroke, with the best epidemiological evidence to date, another study showed that there was significant relationship between depressive symptoms and stroke mortality, even after there's an additional adjustment for education, alcohol, and hypertension. So again, we see this bidirectional, we see this bidirectional effect where there's a strong association between the incidence of stroke and onset of depression. So, and that's independent of disability. So 1 year incidence of major depression after the event was 23.3%, with 3.4 times higher mortality over 10 years, and then a further increased mortality among those with comorbid depression, with the patients with fewer social contacts. And I think this just really highlights the importance of social support. Now, interventions for post-stroke depression, unlike the heart attack, where we saw that antidepressants did have a safe and moderate effect, this isn't the case for stroke. So there wasn't any real association. It was weak evidence for the use of the antidepressants for both the reduction and the submission of or remission of depression and cardiovascular related mortality. although there was one study with a longer follow-up of 9 years that had more positive results and a sustained reduction in mortality. And then finally, we move on to the association between severe mental illness and specifically schizophrenia and bipolar disorder, as well as cardiovascular disease. Now, patients with schizophrenia and bipolar disorder, as I'd previously mentioned, the life expectancy is about 16 to 25 years shorter than the general population. And although unnatural deaths, such as suicide and accidents, are higher in these individuals, it's physical chronic conditions that are the main cause of death, accounting for approximately 70%. So we see here, this is a large scale meta-analysis with these results, that there was 53% higher odds of cardiovascular disease in these patients compared to matched controls without the conditions, as well as that cardiovascular related deaths were 85% higher than the control group. So risk factors for cardiovascular disease, such as smoking, unhealthy diet, lack of exercise, and obesity, are all really quite common with patients with schizophrenia and bipolar disorder. And Public Health England actually reported that patients with severe mental illness have a higher prevalence of obesity, which is actually 1.8 times more prevalent than the general population. But we have to consider that antipsychotics that are used in these conditions, one of the main side effects is weight gain, which is again a predecessor to cardiovascular disease. So again, in this meta-analysis, the incidence of cardiovascular disease increased with antipsychotic use versus control. So the rest of the conditions, we saw a strong bidirectional effect, but for schizophrenia and bipolar disorder, there wasn't so much of a reversal effect. But we did say that there was some proposed, with some studies showing that there was markers of cardiovascular disease preceding and potentially inducing psychosis. So this is just a bit of an overview of the factors associated with cardiovascular morbidity and mortality for severe mental illness. And it's segregated into two factors. This is the patient factors and the healthcare system factors. Patient factors are generally quite modifiable with regards to lifestyle. So smoking rates, lack of exercise, as well as antipsychotic medication and their side effects. We also have the healthcare system factors, where there's maybe a bit of diagnostic overshadowing going on, still negative attitudes and stigma, and again, limited health literacy, all leading to increased risk of cardiovascular disease. So with regards to the mechanisms of these associations that we've just seen and the links, they were once thought to be solely behavioural. So with modifiable risk factors such as smoking, alcohol consumption, poor diet, and sedentary lifestyle, and even patients with cardiovascular disease, they generally, for comorbid mental disorder risk, you would have psychological trauma of the diagnosis, the stigma, again, impact on your role within the family and relationships. But now we're in this understanding where behavior is a big part, but it's a lot more complex than that. And I've portrayed it in the way my brain thinks, is that it's a magnet with a lot of forces going on around it. So you've got the behavioral, but you've also got pathophysiological, where when you experience depression or anxiety or stress, there's clear evidence that mental illness interferes with the body autonomic response. So the heart rate, blood pressure, temperature, and breathing. And this in effect reduces blood flow to the heart and the organs, as well as increasing the body's stress hormone cortisol. Now there was a lot of research for schizophrenia that was characterized by elevated cortisol levels and dysfunction of this autonomic nervous system, as well as oxidative stress and increased platelet reactivity, which all contribute to the development and progression of cardiovascular disease. We also have biological and biochemical. So between the psychological stress and cardiovascular disease, there was one particular study that showed that there was increased amygdala activity, which is the part of the brain that deals with response. With that increased activity, there was increased hematopoietic tissue activity. As a result of that, there was increased arterial inflammation, and then as a result of that, increased cardiovascular disease events. Now, the genetic component there's not too much kind of information on this here, but with schizophrenia, the severe mental illness, they might be genetically more predisposed to adverse cardiovascular metabolic events, as some studies showed that there was increased rates of the dysfunction in first-degree relatives of the patients with the severe mental illness, but not actually affected by the disorder themselves. And then finally, social determinants. This is one that kind of maybe gets overlooked quite a bit because it's maybe slightly more difficult to manage. But socioeconomic status is inversely associated with coronary heart disease. And it's important to note if such of these behaviours do lie in the causal pathway between the psychosocial factors and coronary heart disease, then treating them as confounder variables, which a lot of studies do, must be kind of questioned and something to look into in the future. So I'm guessing a lot of my co-presenters will maybe go into this in a bit more detail, but just as I was researching, these were some of the things that kind of stood out to me that I thought were quite interesting. So metacognitive therapy, this is a type of therapy that was in a study that was by the Great Manchester Mental Health NHS Trust and the University of Manchester, showed significant improvements in the symptoms of anxiety and depression for heart disease patients. So with metacognitive therapy, it helps people to manage their worries and low mood through reducing unhelpful types of thinking, such as rumination and worry. A lot of people are kind of familiar with cognitive behavioral therapy, which challenges negative thoughts and beliefs. However, with that type of therapy, for patients with chronic conditions, a lot of their thoughts are completely valid and realistic. So maybe CBT just isn't the right type of therapy for them. And again, social prescribing, that's kind of really kicked off in the past number of years. So patients with long-term conditions, such as kind of cardiovascular disease, may benefit from the social inclusion and increased emotional support, which we kind of saw with regards to the post-stroke depression. Those with fewer social supports and groups had a 90% increased mortality. And then finally, virtual reality. So this is a really interesting one that I found probably the most interesting, as it could help with a variety of different conditions. So specifically for stroke, where paralysis is a common complication, applied virtual reality methods include 3D games, hand wrist assistive rehabilitation devices, and could help just really improve the patient's ability to learn how to work it and how to use their movements again, as well as kind of rehabilitation through balance and gait training. Also with schizophrenia patients, with the use of concentration improvement interventions to reduce pain and increase the sense of presence. And then finally, for diet management interventions, because with this type of intervention through 3D imaging, VR, virtual reality, it helps to change a high-risk behavior by showing the patient high-risk situations and methods to change the situation. So I kind of just finish off on this Aristotle quote. So educating the mind without educating the heart is no education at all. So it's really just combining the two components and seeing the bigger picture with it all. And that's me.
Lovely. Thank you very much, Marianne. It always warms my heart when I see a presentation that goes from Aristotle to virtual reality. I think if ever there were a compelling case for the World Health Organization, no health without mental health, I think you have thoroughly made it. And for those that are old-fashioned enough to not understand the importance of seeing mind and body as one thing, I hope they and we continue to learn from presentations like that. So thank you very much, Marianne. That brings me to our second presenter, and a long-standing friend and colleague of mine, Chris White. Chris is a colleague at the Mental Health Foundation. He's worked for the foundation for a mere, 12 years, Chris? Since joining in 2011, but he spent over 20 years working in mental health, has a long personal experience of mental health and recovery, and he's worked in a number of mental health organizations during his career. In 2021, he was diagnosed with a serious life-threatening aortic stenosis, and faced 2 significant operations. So Chris is recovering well, and after 7 months of supported sick leave, but he is really uniquely placed to talk about the real value of personal experience and the overlap between mental health and heart health. So without further ado, I will hand over to Chris. Thank you.
Sorry, David. Thanks, David. And thanks, Marianne. Hopefully I'm going to pick up on some of the themes that you touched on there, Marianne, and bring a lived experience kind of perspective to some of those as well. I'm just going to share my screen and make sure that
looking good, Chris. Looking
good. Yeah. So yeah, I want to, a lot of my career, as David says, I have worked with the foundation for the last 11 years. Actually, David, my first involvement with the foundation was with Strategies for Living, which was a foundation project in the late 90s and into about 2002. And a lot of my career, I have worked around recovery and mental health. Latterly, I've had a focus on some of the physical impacts around mental health, but I want to kind of bring some of that to life with up-to-date personal experience in there, but also kind of concentrate on some of the benefits and the case for cardiac psychology. So yeah, I mean, some of these things Marianne has touched on, and you know, the experience of severe mental illness has higher prevalence and incidence of mortality in a wide range of cardiovascular diseases, and Marianne's spoken about that. Depression, 2 to 3 times more common. The increased risk of a cardiovascular disease is also an important factor in high rates of premature mortality for people who have experience of a severe mental illness. And as Marianne kind of went through that research, we can see that there is a bidirectional risk factor as well, biological pathways, but also social pathways, and indirectly social risky health behaviors, which might also have a higher prevalence for people with a severe mental illness. And as Marianne said, things like depression, anxiety, PTSD, there is increased risk of cardiac events. So just to give a personal timeline, and I've put some red flags here as well. So I was born in 1966. I was brought up in a mining community, and by 1980, age 14, I was smoking regularly and went on to smoke for 40 years. By 1985, I was drinking alcohol regularly and excessively. By the 1990s, a combination of factors, but including alcohol consumption, there were frequent psychiatric hospital admissions, some of them quite long psychiatric hospital admissions, and a diagnosis of psychosis, diagnosis of bipolar disorder, and we've kind of already touched on some of those things. Jumping ahead a little bit, around January 2000, I stopped drinking alcohol and started looking at alcohol recovery. And also around the same time, other factors happened where I started looking at my mental health recovery, and those two things worked hand in hand and supporting each other. What I will say during that period is smoking cessation was not encouraged and actively discouraged in some settings and in some clinical settings. You've got a lot going on. You're stopping drinking alcohol. You're recovering from, you're trying to kind of recover from a mental health condition. Let's not complicate things when they're going well by thinking about smoking cessation. So it wasn't until 2015 that I stopped smoking. Between 2015 and 2020, I had a diagnosis of asthma. I had a diagnosis of diabetes type 2, and I was overweight. 2021, along comes a diagnosis of an aortic stenosis. Now, one thing that I will say in relation to me as a patient is that I might not be the typical patient that people experience. I have a high level of health literacy, and I'm highly engaged in my own healthcare. And so, you know, we'll ask for about information, we'll act on information and such. And I know that isn't always the case, and it can be a problem. At diagnosis, one thing that I was told, you know, the first thing that I was told was, well, actually, there's a heart murmur. It's nothing to be concerned about. We need to get a cardiologist to see that. Heart murmurs don't really sound that serious. It's not a kind of threatening language. First appointment with a cardiologist, I get told that I have an aortic stenosis, and that without surgery, it was at a level where there was a high chance of me dying within 2 years. So going from a heart murmur to, oh, you've got this problem and you might die within 2 years, psychologically is a big shock to anyone's system. Thankfully, 13 months ago, September 2021, I had open heart surgery and a valve replacement. And things look good. Psychologically, I kind of weigh up that we've done heart surgery for a long time. It's kind of plumbing. It's correcting a problem where lots of surgery isn't always correcting a problem. And so the future looks good. We have this kind of expectation that recovery will be a smooth linear line, and that things will get back to some level of normality. Actually, recovery quite often looks messy. 2 months later, actually, a year ago, this coming Saturday, I was rushed back into hospital. I had a significant hemorrhage on my kidney, and what we later know was an anticoagulant related nephropathy. So my kidney had an injury, it was bleeding, we couldn't stop the bleeding. And 2 weeks later, I was facing major surgery again, and had to have my right kidney removed. That's a big psychological shock, having 2 major surgeries quite close together. I'll also say during that time, I never actually felt ill. Psychologically, if I'm going to face something life-threatening, I kind of want it to feel big and powerful. but I never actually felt significantly ill. So we're then left in a situation where there's a lot going on. One of the things as a result of that is, my hemorrhage was related to anticoagulants. So I now have to deal with a situation where we need to balance anticoagulant therapy very, very carefully so that we balance the risks of a stroke against the risks of a major hemorrhage. That's a huge amount of information for someone to take on board. As I say, I have a high level of health literacy, and I'm actually very engaged in healthcare and treatment. But that's not always the case for everyone. And when I was going through the rehabilitation phase, people will be familiar with this model of phase one. We've got an inpatient stay, and getting you ready to go back home. Second phase is post-discharge, where we're not really expecting patients to do too much exercise, particularly where there's been significant surgery that needs to heal a little bit. And then after that, the exercise and education phase, and then finally where I am at the moment, that kind of long-term recovery and maintenance plan. But a lot of that focuses solely on physical recovery and not the emotional and psychological trauma that people go through in those phases. For me, the impacts of cardiac trauma: uncertainty, I wasn't sure what was happening; financial insecurity, coping with change, living with side effects, the impact on work, other people's perceptions of stigma. And working in mental health, I have a good understanding of stigma. But hemorrhaging is any kind of bleeding. But when you kind of talk to workplaces about a risk of hemorrhaging, it sounds big and severe and such. So that kind of worries people. Relationships, all of those kind of uncertainties. And unlike in a typical mental health related anxiety, where some of these concerns might be unfounded fears, as Marianne said, actually these are very, very real things that someone has to face. And so I did go through a process of cardiac psychology, and it was metacognitive therapy as well. Heart and mind are inextricably linked. We know that severe mental illness can increase risks of cardiovascular disease, and we know living with a long-term health condition or a particularly cardiovascular diseases, increase the risks of developing a mental health problem. Cardiac psychology is relatively new as a practice. My understanding is currently in the UK, it's only available to around 16% of patients. It's not fully rolled out, but it can help people through those emotional and psychological impacts of dealing with the trauma and putting back together the pieces of the changes that a significant cardiac event has on people. That might be overcoming anxieties around your health, having a look at kind of, well, what does a stable home look like? What is a safe place? Purpose, can I go back to work? What supports do I need to go back to work? And what are the impacts on my community and my social networks? They were the kind of 4 areas that certainly for me, we concentrated on in very direct kind of responses. We also know that there are positive outcomes from taking that approach. Evidence suggests that psychological attributes, especially things like optimism, lead to better recovery rates, and that also kind of lead to better engagement with other therapies like healthy eating, physical activity. One of the things when I was going through physical rehab and talking to therapists and nurses is they struggle to engage with people in physical rehab, with people who have a serious SMI. They don't turn up for physical rehab programs. They don't engage in healthy eating programs to the same level as other patients, and that will have a negative impact. And we also know that positive psychological interventions have an improved results in terms of well-being and reducing ongoing depressive symptoms. So this looking not just at the physical rehab, but also the psychological rehab for people experiencing severe cardiac trauma. Okay, David, I will stop sharing.
Thank you, Chris. Sorry, my connection went a bit wobbly there. It's real pleasure, Chris, to see your presentation. It's great to see you back doing good work, and I look forward to catching up with you in the foundation in the near future. But thank you very much for that presentation, and thank you so much again for underlining those absolutely unbreakable links between physical and mental health. From a very complementary perspective that sits well with our first presentation. Just to remind folk that we have a Q&A function that people can use if thoughts, comments, questions are prompted by any of the presentations. What we have now is a chance for two expert commentators to respond and reflect on the presentations that we've had so far. Our first responder is Bernard Chung. I apologize if I messed the surname, but as a Crepaz-Keay, I'm used to surname challenges. So Bernard is a professor in cardiovascular therapeutics at the University of Hong Kong, where he heads the Division of Clinical Pharmacology and Therapeutics in the Department of Medicine. He's an honorary consultant physician of Queen Mary Hospital and the medical director of the Phase 1 Clinical Trials Centre there. He's editor-in-chief of the Postgraduate Medical Journal, and his main research interest is in cardiovascular disease and risk factors, including hypertension and metabolic syndrome. And really importantly for today's process, Bernard is a trustee of the Cardiovascular Research Trust. So it's with real interest that I'm going to pass the floor to Bernard. Thank you.
Well, thank you very much, David, for reading out my CV, and I think that's about it. Now well, I'm very grateful to Marianne and Chris for really, giving us very interesting and as well as comprehensive introduction to this interesting question of the links between cardiac and mental health. And I also learned a new term, cardiac psychology. And perhaps there should be a sort of, psychocardiology as well, in the same way as, cardiovascular disease and oncology are related. And in recent years, we have oncocardiology. And I think that probably points out the problem that doctors have, because we are trained either in it's internal medicine, including cardiology. And on the other hand, psychiatrists undergo a different training. So very often the, let's say, cardiologists cannot treat, or perhaps even will not diagnose or recognize mental health problems. And at the same time, psychiatrists may under-recognize cardiovascular disease in their patients. So I think that's something that perhaps, we'll address later on, and perhaps Russell will address later on. But let me first comment on the issues that Marianne has discussed. And then I'm first of all, I'm going to look at it from a very sort of, simple and perhaps even somewhat naive angle, as to how cardiovascular disease can be related to mental health and vice versa. Now, I mean, I see patients, so we commonly encounter patients who have cardiovascular disease who are very anxious or depressed. I think both speakers have mentioned the high rate of depression amongst people with cardiovascular disease. So that in a way, it's to be expected. And as Chris described his own experience with his aortic stenosis, for a doctor, we may have seen dozens or hundreds of such cases, but for the patient, it could be a devastating diagnosis. So, I think as practicing clinicians, we really should recognize anxiety and depression in such patients. Perhaps the majority may not need drug therapy, but certainly, recognizing the problem is a good start, and judicious referral. So that's cardiovascular disease causing anxiety and depression. What about the other way around? Well, anxiety is certainly a very well recognized cause of high blood pressure as well as chest pains. In fact, we even have this label called white coat hypertension to describe those whose blood pressure is normal at home, but when they come to the clinic and they see a doctor in a white coat, the blood pressure goes up. And, we're not saying, going up a little bit, it really goes up by 20, 30, 40 millimeters of mercury. Now, I myself actually suffer from this problem. I recently went to have a health check, and no matter how many times they checked my blood pressure, it was very high. But I know that at home, it's not that high. So anxiety can lead to elevated blood pressure and also chest pain. Now, there are many causes of such what we call atypical chest pain, non-cardiac chest pain. However, the issue is not as simple, and perhaps that's what keeps the cardiologists in business, because you do get the minority of patients who have genuine ischemic heart disease, and when they're under stress and when they are anxious, they have their angina attack. So that is that can also occur, although perhaps in a minority. And then in recent years, there is even this entity with a Japanese name, Takotsubo cardiomyopathy. Now, another name for it is broken heart syndrome, that you might read in popular press. Basically, it's a emotional stress-induced dysfunction, malfunction of the heart, if you like. So, and that's physical, because you can demonstrate ECG changes, you can demonstrate that there are normal movements when you look at it with cardiac ultrasound. So that's something in between. So emotions that can actually cause heart dysfunction, luckily, it's reversible or largely reversible, and also it is only transient or momentary. Patient will recover, so it's not a heart attack. So again, that shows that we mustn't just dismiss somebody's chest pain as being caused by anxiety. There may be at least pathophysiology, if not actually a pathology behind that. Now, of course, anxiety can also increase your stress hormones. Cortisol mentioned, adrenaline is another one. And adrenaline, you know, is not to be underestimated because, okay, you know, it sends your heart racing away and you can actually get a heart attack and die if, you know, if there's too much adrenaline. Now, what about depression? How does it cause heart disease? Well, one popular theory is that if you are depressed, you are less physically active, and therefore you are more prone to heart disease. That's one way. Or perhaps there's decrease in compliance, decrease in health-seeking behavior. So that's possible. In addition, in recent years, we know that depression is also related to inflammation and even platelets. You know, in a depressed person, the platelets are more likely to aggregate and cause thrombosis and cardiovascular disease. So that's another mechanism. Now, what about psychosis? Patients with psychosis are treated with drugs, and many of these drugs actually have adverse cardiovascular effects. Many of these drugs cause weight gain. And if you gain weight, you get, you know, elevated blood pressure, elevated lipids. In other words, we call it the metabolic syndrome. So it's I mean, we heard from the two speakers that mental health and cardiovascular health, there's a bidirectional relationship between the two, and that's very true. So perhaps we can very briefly summarize the possible mechanisms. What are the sort of biological mechanisms that link the two, apart from behavior, or perhaps I should say, you know, biochemical mechanisms linking the two? Well, one is inflammation. We've mentioned that. And inflammation, it really is a fundamental pathological process that underlies a lot of the diseases or health conditions we see. So cardiovascular disease really has inflammation as a very important pathological mechanism, you know, as to how cardiovascular diseases develop. But more recently, it's been recognized that inflammation also plays an important role in the pathogenesis of depression and psychosis. So that's a discovery in recent years, that it's not all in the mind. There are some biochemical changes in the body when a person is suffering from depression and psychosis. Now, other mechanisms include, and they've been mentioned, I mentioned platelet dysfunction earlier on, and that can cause thrombosis. I think, you know, Marianne also mentioned stress. Cortisol and adrenaline are stress hormones. So that can also be the mechanism linking cardiovascular disease and mental disorders. I think Marianne also mentioned oxidative stress as a particular kind of stress. And you know, in a person who is obese, who has got, you know, high cholesterol levels, they will be under oxidative stress. And the oxidative stress, one of the consequences of oxidative stress, it causes endothelial dysfunction, and that is the malfunctioning of the inner lining of the blood vessels. And if there's a problem there, then you're more likely to develop atherosclerosis, hardening of the arteries, as well as thrombosis. And then lastly, another mechanism Marianne mentioned was autonomic dysfunction. Now, what does one mean by that? Well, basically, it means an aberration in your heart rate and blood pressure. And, you know, if you have increase in heart rate, or if you have increase in blood pressure, so that can naturally lead to cardiovascular disease, heart attack, and strokes. So I think perhaps to tie everything in, I would want to mention something that's very old. The 4 leading factors that cause cardiovascular disease. And that was discovered in the Framingham study, half a century ago. So hypertension, blood pressure being one of them, diabetes, and I suppose we can now include not just diabetes, but weight gain, overeating, lack of exercise as part of this metabolic problem. And then again, associated with metabolic problem is the lipid level, high cholesterol. And then the 4th factor is smoking. Now, smoking does come into this because if you are, depressed or under stress or anxious, you might, and if you're a smoker, you might take a cigarette and smoke. So that can also be a kind of confounding factor, if you like, underlying factor in the link between mental problems and cardiovascular disease. And worst of all, as you know, it's very actually, our patients are not very truthful when it comes to, how many cigarettes they're smoking. So it's something that is very difficult to control for in a study and to gauge. And they may not even be aware that they are smoking more when they are under stress, depressed, and so on. So I think with that, I'd like to hand over to Russell, who can tell us about what we can do to improve our management of psychological, psychiatric disorders in patients with cardiovascular disease and vice versa. Thank you, Russell.
Excellent, thank you. I know I will briefly introduce Russell. Thank you, Bernard, for a very helpful and stimulated response to the earlier presentations and underlining the importance of the evidence. I mean, inflammation for me feels like a really big one, and I remember having a discussion about the emerging understanding of the relationship between food and mental health, and so much of that looks like that's going to be about inflammation, vascular inflammation. And I think that feels to me like one of the really most important emerging factors in both mental health and cardiovascular health. So that's really, really helpful. Thank you. Russell, Professor Russell Roberts is director of Equally Well Australia, has extensive experience on shaping partnerships, services and events around the connection between mental and physical health, has a particular interest in cardiovascular health as well. He's also a professor of management and leadership at Charles Sturt University with a particular focus on mental health. So it's a real pleasure, Russell, to hand you the floor for our final reflection on the discussions today. Thank you, Russell.
Thanks, David, and it's my privilege to be part of this, and thank you for the invitation. I'll just reflect a little bit on what David and Marianne and Bernard said, and then move on. And I think it complements really nicely. David, thank you. This is such a powerful account of your lived experience of a mental illness and the relationship between that and physical illness. And, while it's a unique journey, when I look at that journey, there's so many commonalities there that people living with mental illness have in respect to their physical health journey as well. So thank you for sharing that. It's incredibly powerful. And that journey, that long journey, is so common. And that's something that we're really so valuable for us to think about and address when we think about how we work in mental health services and how we support people with a lived experience of mental illness. And Marianne, great review. And I think a brilliant review of the relationship between the mind and the body and the reciprocal relationship. And Bernard, I think you really unpacked that brilliantly in terms of some of the pathophysiological mechanisms in that respect. And I think it speaks to our need to consider a whole person, a person who is mind and body, heart and psychology. And I think what I'm going to add to that is to think more about, yes, this is a whole person who navigates health systems, and who tries to navigate the existing mental health system and physical health system, and is also part of a society. And I'm going to try and give some evidence of how we let people down in their navigation, in their journey in contact with health systems. And some of the things we can do better. Bernard, you're so right in picking up the gap between sort of physical health clinicians and cardiologists and psychiatrists. It seems that one leads it to the other, and then it falls in the gap. And that happens in primary care as well, for GPs and for mental health professionals. Both think the other is doing it or leaving it to the other, and in the end, no one's doing it. And consequently, the outcomes for people with mental illness are diabolical. This is, quite frankly, a national and international shame. And thank you all for being, committed to this problem and this issue. I'm going to share my screen now. I'll just double check that it's coming up.
Looking good, thank you.
And I'm just sharing that it's a whole slideshow. And
Yeah,
really
looking
the
good.
question we've got to ask is, why do people with mental illness have 3 to 6 times the death rate, early death, premature death due to cardiovascular disease? This is a question where we looked at some of the reasons. I'm going to look at some of the other reasons and also take a bit of a population health approach in terms of some of that data. When we look at it, Marianne, you mentioned this, between 30 and 25 years, when we look at the general population, people with mental illness are about 2.4 times the chance, and people with psychotic illness, over three times the risk of premature death of any disease. Particularly in this slide, people with serious mental illness are 6 times more likely to die from cardiovascular disease. And the question is why? We've all posed some of that. I'm going to pose some other areas. Overall, for all chronic diseases, at least the top 10 chronic diseases, the 13% of population with mental illness comprise 55% of all premature deaths. Something's going wrong here. And this is a bit of an argument I'm going to progress, through the next 10 minutes. We worry with mental health about the risk of suicide, but really, for every one person who dies prematurely of suicide, 10 die prematurely of 4 causes: heart disease, respiratory disease, cancer, and diabetes. So it's right to be concerned about suicide risk and address that, but we do need to do a lot more addressing the major causes of premature death in people with mental illness, which are these chronic conditions, the majority of which are preventable. Here's some data from Australia. And this, we're just actually redoing this data. This is the whole Australian population, data from everyone who's contacted medical services. And these are not people with serious mental illness. These are people who contact their GP or pharmacist for any mental health related service. So this includes people with mild anxiety and mild depression, as well as people with severe mental illness. The key numbers I'm highlighting here is every year, and this was 1 year, but the figures move a bit, but not a lot. 17 out of the almost 5,000 premature deaths across Australia of cardiovascular disease, 1,740 were from people living with mental illness, and that's and compare that to the people with mental illness who die of suicide, 943, almost half. Or almost cardiovascular disease death are almost double. They're for people with mental illness than those for people with mental illness with suicide. So this is a major problem, and the second leading cause per absolute number of premature death. Cancer tops it, but not by a lot. How does this figure in terms of risk? And remember, this is people with mild, any mental illness. This is the increased risk, and we just published this about a month ago in the International Journal of Environmental Research and Public Health. And you look at the increased risk, so that of the total Australian population, which is about 25 million at the time, 12.8% of that population access mental health related services. Of that 12%, comprised 64% of chronic respiratory disease, and Bernie just spot on about smoking. And can I give a bit of a plug for the narrative literature review, which we have, which has a section on smoking. There are so many myths about smoking. Smoking kills at least 1 out of 2 long-term smokers. It's something that we really need to deal with, whilst respecting autonomy of individuals to make those choices. but we should not presume that people are not capable and they don't want to quit smoking. The rates in that respect are pretty well equal to the rest of the general population. When we look for heart disease, it's not as bad, it's much better, but it's still pretty bad. The 13% comprise 36% of all deaths. So really, there's the 3 to 6 times risk. These are people with mild mental illness. Now, there's a question about why, and that's just a little bit of the Australian data, and I'll just do a real quick snapshot, because I've only got a few minutes. But I'll look at the other side that I think, Marianne, you unpacked a little bit too, is, so I'll just go back. So really what I'm arguing there is we should pay attention to the physical health of people with mental illness, because people with mental illness are much higher risk of premature death. And as David outlined, Chris outlined, this is usually preceded by decades of poor health. So whilst we look at the death rates, this is preceded by decades of functional impairment and poor health. That's my first point I want to make. We really need to pay attention to this as physical health clinicians. Second point, and it's your point, Marianne, as well, it's well established that poor health is associated with poor mental health. Probably increases it by about 5 times. And once again, it's a reciprocal, two-directional relationship. It's pretty hard to unpack. The message, though, I think is we really need, if you look after someone's physical health, it's going to improve their mental health. If you look after someone's mental health, it's going to improve their physical health. Message is we should be looking after the whole person and working together in that way. This is another thing that I'm looking to, has been overlooked. Continuing that argument, when we look about reducing suicide and we talk about the premature deaths with suicide, which, by the way, there's far more from chronic physical illness than suicide. But if we're worried about suicide prevention, which we are and should be, mostly we talk about, families and mood disorder and substance disorder. But really, something we haven't looked at and haven't addressed seriously is improving physical health. Why on earth have we not done this seriously? It's the most commonly associated thing with suicide completion. Yet we do with all these other things, which is great. But once again, this could well be an overlooked suicide prevention strategy. Once again, of merit of itself, we should be looking after people's physical health in the first place. So now I'm going to say, well, why is this so? What's happening? This is the money slide. So there's all these sorts of reasons, and it's quite true. There's a lot of predisposing factors associated with people living with mental illness. But this is a telling slide, which really shows at every contact with a health service, people with mental illness get poorly treated. They are just basically in Australia, we call this structural discrimination. So whilst, and the same data and profile is the same for cancer. And the data for cancer is while people have the same or lower incidence of cancer, the death rate is much, much higher. Now, when we look at heart disease, much the same. Whilst the rate of procedures and hospitalisation is much lower, the death rate is high, particularly for psychoses and other psychoses. This tells me that we are failing people with mental illness and not treating people equally, hence equally well. We really say that people with mental illness should get equal treatment and equal access to health services, and they're not. Now, sometimes that needs affirmative action. So be it. We know about affirmative action, we should be doing it. Another mechanism is diagnostic overshadowing. Someone with a mental health condition shows up to a general practitioner or physical health specialist. Often, the person will focus on the mental illness. And David, you had a bit of a hint of this. We did a large research study, and the links to all of this stuff and these resources and consensus statement, the narrative literature review, and a lot of the publications are on equallywell.org.au. All the documents and publications and resources are there, and that link is on every slide, so I don't have to go back to it because I know it's sometimes hard to jot that down. But the other side of this is when people with mental illness rise in physical health concern, often it's overlooked. People get concerned and they don't treat it seriously. We found that about GPs are pretty darn good, but mental health professionals are dreadful at this. In Australia, half of if a person raises a serious side effect of medication or health concern, only half of them feel as though they're being treated seriously. This is shameful. This is just not good enough, and there's something we're looking to address. And then there's the other side, diagnostic overshadowing. People get concerned about that mental illness, focus on the mental illness, and because of the system, they don't look at underlying asymptomatic chronic physical health condition. Consequently, people are dying because, you know, they die suddenly of stroke or of heart disease or of undiagnosed cancers. If they're caught early, could have been prevented, but if left for a long time, prove fatal. Now, we're gambling on this, and really in Australia, and I think the data is probably not much different, 80% of people with mental illness have at least one chronic physical health condition. So we argue when any person sees any primary physical health person, they should ask about, you know, about their mental health, they should ask about physical health, because chances are 4 out of 5 that they'll have a chronic physical health condition. They're pretty darn good odds if you go into the concern. And, you know, that's the gamble that, in a sense, they're the risks that people living with mental illness are taking, and the evidence is they're losing in that game. So what are we doing? You know, Bernard, you mentioned this, you know, almost over two thirds of cardiovascular disease is to do with the 10, the joint effect of the 10 modifiable risk factors. And so us in Equally Well Australia and our friends who I know are online in Equally Well UK and Equally Well New Zealand are really trying to address this in a systemic way. And for example, Equally Well New Zealand has done some great work in terms of advocating around cardiovascular disease risk assessment. And you notice in those guidelines from the New Zealand government, it's small and it's highlighted that people with severe mental illness are recommended to be screened at 25 years and over. So when they reviewed their guidelines in 2018, they said people with serious mental illness are at a high risk component and there should be regular screening at 25 years and over. And, you know, that's partly, someone put in the Q&A about some of the great research. Ruth Cunningham in New Zealand is doing some brilliant research about cardiovascular disease risk with people with severe mental illness. In Australia, once again, we're working closely. The Australian Heart Foundation are now revising their guidelines, first major update in 10 years. And we're trying to advocate that this is, that the risk is appropriately reflected in the revised guidelines for assessing and managing cardiovascular disease. And that's us. So really what we're arguing, and I've got the, and that will be on the recording and on the slides when they're shared, all the references are there. So really, this is a major issue. Thank you so much for dealing with it. And there's things we can do, I think, by making sure that people living with mental illness get equal access to primary care, to specialist care for their physical health, because otherwise, this situation, which has been evident for at least 20 years, but for the last 15 years, the gap seems to be getting larger, not smaller. And so this is something we really need to try and address at a systemic level. So thanks. And
thank you.
Some references which we'll share, and very happy to share others as well.
Lovely. Thank you so much, Russell. Another really powerful presentation. And I know one of the things that we've been saying in the mental health activist world for a long time is discrimination kills. And you know, that is not a meaningless slogan. That's an evidence-based statement of fact, which you and others have underlined absolutely fundamentally. And I'm, you know, the diagnostic overshadowing is something that is, you know, is very widespread. In the first GP I had as an adult, the first thing they would do when I went in to ask about a problem was they'd bring out my notes and they lumped them down on the desk, and 80% of them were about my psychiatric background, and that completely overshadowed their approach to me. You know, I changed them because I share Chris's health literacy, and I know that's what I'm entitled to do in the UK. My GP now is fantastic, and what she does is she focuses on what I'm talking about. And I went to her recently with something, and the first thing she did was go to blood screening, and all the kind of stuff that you should do for top quality care that anyone should expect. And I think it's just shocking that a psychiatric diagnosis is a barrier to getting that. But anyway, thank you. Before I take up all the remaining time ranting on that one, thank you so much to all our speakers. We have a few questions, and we have a little bit of time. We got about 10, 15 minutes of time. So I'm going to test my technical competence to its limit and see if I can field some questions to you. And if you can just kind of indicate by waving if any of you are interested in taking that, that will help me a little bit. Otherwise, I'll just throw them at Chris because I know him best. And the first one actually is what are the most promising directions for future research into the links between mental health and heart health, cardiovascular health? What are the most interesting? Okay, lovely, Russell.
I might go on and then throw it to the others. You know, I think where we can make really good progress, and it's nascent and it's just emerging now, is to look at the lived experience and the consumer perspectives of the way they navigate a service. Traditionally, the research has been done from the perspective of services as delivered, and it's not really working. So really, we're trying to turn around the research and start to look at, you know, the perspective of the services as received, and so to get the experience of lived experience. I think that's and I think the really other exciting thing is the co-design is where people with lived experience and the clinical experts and the system experts get together, each respecting their experience and expertise to design research. So it's a really comprehensive view of the entire system, because you know, some of that other research, which is vitally important for understanding some of the pathological mechanisms, it has failed to understand that there are people who are navigating health systems, and mostly, even in the best societies, their health systems are you know, not 100%. They've got a lot of improving to do. So I think that's you know, one of the really promising areas of research from my perspective, and a different area of research.
Lovely, thank you. I don't know, Chris, do you want to underline that? Because I know.
Yeah, I think for me, one of the things is a lot of the risk factors that we know where someone has a severe mental illness, diagnosis and treatment of that on a psychological level might be in early 20s, early 30s, but actually the longer term physical impacts are 50 plus, and we don't start putting in interventions, physical health interventions at the diagnosis stage at 20 and 30. So by the time some of these risk factors come to medical attention, actually a lot of the damage has been done. So we need to put some kind of longitudinal studies in of, we know some of the risk factors, we know some of the risks of some of the medications leading to weight gain, leading to diabetes and such. So we really need to start kind of, you know, in terms of preventative mental health, we need to also be talking around preventative physical health harm as well for that group of patients.
Lovely, thank you, Chris. I mean, one of the things that I've noticed when we're talking about these crossover interventions, when we're talking about looking at things that fall under more than one specialism, and I don't know, it'd be interesting to reflect on other countries' approaches, but the UK is really siloed in its approach to health interventions. So you see the expert in cardiology for that, you see the psychiatrist for your mental health, and they're like kind of, you know, the ivory towers, and I don't mean that in a harsh way, just completely siloed from each other. And we need to do something that's much better at kind of linking those up. And if that isn't happening at a primary care level, at a kind of family doctor level, it seems quite hard to see where it might be. I wonder if that's reflected in Australia, in Hong Kong. And I know, Marianne, you've studied global mental health, and whether whether that's something that's other countries are doing better. Are there better ways of doing it than our silo approach?
I don't know if Marianne wants to respond, but certainly, David, in response to your question, yeah, it's exactly the situation in Australia. The services are very siloed, and there's a lot of work. I think that's the other area of research is, doing integrated care and connected care. There's a lot of emphasis on that, but certainly in Australia, it's very siloed, and it's even worse because we have the different jurisdictions. So health services are not mainly provided by the states. So every state has it different, but some of them are through the Commonwealth and some are from non-government organisations. So not only is it siloed, it is fragmented. So and that's why what some of the research we're looking to do is the impact of peer navigators to help people navigate this system and advocate through this system.
Yeah, lovely. That's really helpful, Russell. Marianne, I know one of your professional skills is in community pharmacy, and I know from work that we've done with many service user groups that they've actually found community pharmacies to be a really good independent resource for looking across, certainly different medications that they might be taking, or things that might be possible, or the way treatments are interacting. I mean, does that reflect your experience, or the things that you think that can bring to the table?
Yeah, for sure. Like kind of coming from Northern Ireland as part of the UK, so we do have obviously funding issues and things like that. But generally, community pharmacy is the kind of first point of call for patients, and it is highly accessible. It is very good for patients or even pharmacists to kind of pick up about the cardiovascular health, because usually we would do kind of blood pressure readings, as well as kind of even having a bit of an inkling into how a patient's thinking, because it would come into us quite regularly. But again, there is still that stigma for patients, and especially kind of in Northern Ireland here, the stigma is quite big. Also in the Republic of Ireland, kind of on the west coast, like County Donegal, the stigma is huge. So it's really trying to bridge the gap between kind of healthcare professionals being more aware and including patients, as well as trying to just get the awareness and education out. But I think even in like third world countries, the stigma is again huge. And that's even within the general population, if you still have that stigma, everyone's affected by it. So it's just trying to bring everyone closer together and raise awareness for both of them.
No, thank you very much, Marianne. And we're coming a little bit towards the end of our time now. So I'd like Bernard to give you as a trustee of the trust kind of final words and thoughts. And particularly if you had a magic wand, what would be the kind of one thing that you would do to steer us all in the right direction over the coming years? Not that that's a big ask in 2 minutes, but let me see how you can do.
Oh gosh, David, thank you very much. Well, I mean, this is a very, very enlightening seminar, because various doctors don't actually talk to each other, as you said. They live in silos, separate silos, very much. So I think it's very useful to have this cross talk, if you like, between cardiac and mental health. Is there a magical wand? I don't think there is. Perhaps we have to go back to our family doctor, the GP, who would deal with and who has expertise in dealing with both physical health and mental health. So I think that might be the easy way forward. And I have to admit that sometimes when you see a patient who has let's say no demonstrable coronary artery disease, and in fact we had the question about non-obstructive coronary artery disease, then very often cardiologists lose interest, because the patient can then go on medical therapy and perhaps even be, discharged back to the care of their GP, without recognizing the stress that might, underlie that, and also the anxiety and depression that the physical condition can create. Oh, unmute yourself, David, please.
I was going to do it sooner or later. Thank you, Bernard. Yeah, thank you for that. I, for one, have just hugely enjoyed listening to such a good range of presentations. I've learned a huge amount across both of those fields. Certainly, things like cardiac psychology, it would be great to see that more widely available. It would be great to see anything that brings those links across those boundaries. I would also like us to see us doing much more cost benefit analysis, because we know the way we're doing it now is costing a huge amount, not just in terms of psychology and heart health, but pure economic terms. This is, we're doing it very, very badly wrong in a way that we can't afford to continue to do it so wrong. So thank you so much, all of you, for contributing to this. This will be, the recording of this session will be made available through Cardiovascular Research Trust and Mental Health Foundation as soon as we can make that happen. Marianne, Chris, Russell, Bernard, thank you all so much for sharing your time and wisdom during this. Thank everybody for joining us, and please keep in touch and look after yourselves with your newly acquired knowledge, both heart and mind. Thank you very much, and have a good rest of your day.
Thanks, David.
Thanks,
so much.
David.
Excellent.
Thank you, David. Bye.